It's a new year, so I thought I'd bring you guys new content. Happy New Year to each and every one of you individuals. I hope you guys are doing great. I know I haven't been posting on the channel recently, but here's a video that I thought I would do for you guys. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at the active management of the third stage of labor. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to receive notifications of such amazing content every time I post. Grab a piece of paper, grab your pen, and let's go. So the objectives of this class, I just want to talk about the active management of the third stage of labor, and I want to talk about manual evacuation of the placenta. So remember that labor is divided into predominantly 4 stages. Some literature quote 3 stages. The first stage, which is going to be when there is regular uterine contractions up until the cervix is fully dilated. The first stage is divided into 2 phases. The latent phase, from when the cervix is closed, the regular uterine contractions start, to when the cervix is about 3 centimeters dilated. And the active phase, when the cervix is 4 centimeters dilated up until 10 centimeters dilated, which we call full dilatation. Second stage is where starts off from when the cervix is fully dilated to delivery of the fetus. And the third stage is delivery of the placenta and the membranes, which is what we'll be focusing on in this particular lecture. We have some literature that actually quote for the 4th stage of labor, which is usually 1 hour. Sometimes it can be extended to 6 hours, where you actually monitor the vitals of the patient and assess for any bleeding. Remember that the 3rd stage of labor, like I said, is going to be commencing when you have delivered the fetus, and it ends with the complete delivery of the placenta and the attached membranes. Ideally, the length of the 3rd stage is going to be between 5 to 15 minutes, but there is a bit of debate about the absolute time limit to when we can say that the 3rd stage has actually prolonged. But though some literature has actually suggested a time range between 30 to 60 minutes. So active management of the 3rd stage of labor generally is going to be preventing conditions like postpartum hemorrhage, which is going to be the leading cause of maternal morbidity as well as maternal mortality. Remember that over the course of pregnancy, the mother's blood volume actually increases approximately by 50%. So that's increased about 4 to 6 liters. Then this plasma increase is going to be somewhat more than the total number of red blood cells that are present. So there is some sort of hemodilution, because now you have more plasma and the total red blood cells kind of like almost remains the same. So it will look like you have less red blood cells in essence. Kind of like if you have water and tea, then you add sugar to it, it's sweet. Then you add more water, you haven't changed the amount of sugar that is inside, but you have changed the concentration in the fact that you've added more water. So remember that this decrease is smaller in women who take iron supplements, whereas there is a 4 that's much more dramatic in those that don't take the iron supplements because they have limited iron stores or are anemic upon them becoming pregnant. Remember that this increase in blood volume is going to be helping in perfusion demands of the low resistance uteroplacental unit, and it's going to be providing this reserve for the blood loss that we anticipate to happen when this woman actually delivers. Remember also that the increase in the blood volume is also going to be protecting against hypovolemia that's going to be caused by a decrease in venous return and a decrease in vascular tone due to the high levels of progesterone. Because remember, progesterone is a smooth muscle relaxant that actually causes blood vessels to dilate. There are also some changes that happen during pregnancy to the coagulation system, and there's going to be a marked increase in the clotting factors and a decrease in the fibrinolytic activity. The platelet count also tends to slightly fall during pregnancy, and this is because of the dilution that is happening, where you have an increase in the plasma volume, and sometimes there is this low-grade consumption of platelets that usually happens, and individuals with platelet volume that is increased and activity generally tends to be maintained. Remember that even though the uterine contraction is initially going to be responsible for controlling the blood loss at the placental site, the clot formation and fibrin deposition actually occur rapidly and are essential actually to maintain this hemostasis and to promote the involution of the uterus in the following days. Remember that the uterus has these muscles that are crisscrossing each other, and in between these muscles are blood vessels which are present. And these blood vessels, when the uterus actually contracts, they clamp down on these blood vessels, and this helps prevent further bleeding, which explains why it's quite difficult for bleeding to stop in the placenta previa, because the placenta is placed on the lower segment of the uterus, which doesn't have this arrangement of the muscles. In addition to this, to the clamping down mechanism of the muscles that are crisscrossing across the blood vessels, you also have this clot formation, the fibrin deposition at these bleeding sites that is going to be promoting this hemostasis. Remember that in early pregnancy, the uterus grows dramatically from an initial weight of roughly about 70 grams and a capacity of about 10 mils to a term weight of about 1.1 kg and a capacity of about 5 liters. And you also get these changes in the hematological as well as coagulation system. You get high levels of estrogen that are going to be promoting and allowing changes in the uterus. So this initial growth that's going to be happening in the uterus and the ultimate growth of the placenta and the fetus actually requires a growth in the blood flow to the uterus during pregnancy, such that at term, the blood flow to the uterus is roughly about 500 to 800 mils per liter. This is very important because they do ask you this on your MCQ questions. So this is going to be representing a cardiac output of about 10 to 15%. Remember that most of this flow is going to be traversing through the low resistant placental bed. So after someone delivers, like I already told you, the placenta gets sheared off and the underlying endometrium remains. And if the uterus doesn't contract, that site will keep bleeding. So this separation is going to be primarily occurring by this reduction in the surface area of the placental site as the uterus begins to contract in it as it begins to shrink. And remember that the decrease, this decrease is caused by this myometrial retraction, and it's actually a unique characteristic of the uterus. Like I said, you have these blood vessels that are within the muscle layer and are crisscrossing. So in this way, the placenta is actually undermined, it's detached, and it's propelled into the lower segment. So the second mechanism for separation is through the hematoma formation, which is due to the venous occlusion and the vascular rupture in the placental beds, which are going to be caused by these uterine contractions. So as this uterus then now, rather the placenta actually detaches, then the spiral arteries which are exposed now are going to start bleeding if the uterus is not contracting. So the vessels that are supplying the placental bed actually are going to be going through this lace network that is crisscrossing muscle bundles that can sometimes kink off the blood vessels as they contract or sometimes retract following expulsion of the placenta. So this is what we call as the living ligatures or the physiological sutures of the uterus. So remember that several agents can help with uterine contraction and the severity of the myometrium to oxytocin, or sensitivity rather of the myometrium to oxytocin, which is like a nonapeptide, which consists of 9 amino acids that is produced in the hypothalamus and released from the posterior pituitary gland, is generally going to increase as we go late in pregnancy and even during labor. Remember that this locally produced and even exogenous prostaglandins, such as the prostaglandin F2 alpha, are going to also contribute to myometrial contractions. Synthetic ergots, alkaloids, are going to be causing this tetanic contraction of the uterus. And you also have some agents that can cause uterine relaxation and can actually be dangerous, such that they may result in bleeding because you don't have that living ligatures or that physiological suture where the uterus contracts on these blood vessels. So you may have some beta sympathomimetics like ritodrine, you may have terbutaline, salbutamol, which can also relax the uterus via the beta-2 stimulation, and you have some non-steroidal anti-inflammatory agents that have dual action. They have both anti-prostaglandin effect and the antiplatelet effect, which is why if patients are on aspirin, we often tend to stop it at 36 weeks. This is all quite important because this is very important as it affects the third stage of labor. Remember that the former effects that make these drugs useful to treat the dysmenorrhea and the after pains, both due to uterine cramping, but the postpartum period, the PPH can actually follow, and you actually want to have the uterus contracted. Some calcium antagonists such as nifedipine, to some lesser extent even magnesium sulfate, can also inhibit uterine contractions and have been used as tocolytics, and the nitroglycerin as well as some inhaled anesthetics can also decrease uterine contractility such as halothane. So giving this woman a uterotonic agent can actually help with contraction of the uterus. And remember, oxytocin as soon as the fetus is delivered, and this uterotonic drug is going to be helping the uterus contract firmly and decreasing bleeding due to uterine atony. And this is the most common cause of postpartum hemorrhage. Remember that the oxytocin is going to be given as 10 international units intramuscular, or as an infusion of 20 international units in 1000 mils of normal saline that can run at 125 mils per hour. And remember that oxytocin shouldn't be given as a bolus because it can cause hypotension. So here's a large difference between physiological management of the active stage of labor, or rather the third stage of labor, versus active management of the third stage of labor. So the main difference is oxytocin. In physiological management, we don't give any uterotonic after delivery of the placenta, while as in active management, we do give oxytocin with delivery of the anterior shoulder or the delivery of the baby. With physiological management, we have this assessment of the size and the tone. Same thing is happening in active management. With physiological management, there is no cord traction that is there. With active management, there is what is known as controlled cord traction when the uterus is contracting. Never should you pull on the umbilical cord or try to pull on the cord if the uterus is not contracted, because it can actually lead to prolapse of the uterus. Then cord clamping is rather variable. You may sometimes delay cord clamping in physiological management, while as in active management, you generally tend to clamp the cord quite early. Remember that the gentle traction in the controlled cord traction should be done with counter traction to the uterine body, because you want to prevent prolapse of the uterus. I'll show you a picture of how this looks like. So generally, there are some traditional signs that we're taught to help you judge the placental separation and see when placental separation has happened. But because of active management of the third stage of labor, we generally don't really focus much on these traditional signs. So the first sign and the most reliable sign is actually lengthening of the umbilical cord, as the placenta actually separates and it pushes into the lower uterine segment by this progressive uterine retraction. So you should ideally place a clamp very near to the perineum, and this actually will make it very easy for you to appreciate that this cord is beginning to lengthen. And you should never place any traction on the cord without counter traction to the uterus above the pubic symphysis. Like I said, if you do this, you may actually cause the uterine to prolapse, or you may cause the uterus to invert. And the second sign is that the uterus will become globular and will become firm. I usually like to tell people that it feels like a tennis ball. So this usually occurs when the placenta actually descends into the lower segment and the body of the uterus actually continues to retract. And this change may actually be clinically difficult to appreciate, but if you have been palpating a lot of these uteruses in labor, you'll be able to tell this. The third thing is that the uterus actually rises in the abdomen, and the descent of the placenta into the lower segment and finally into the vagina displaces the uterus upwards. The fourth thing is that you may sometimes notice a gush of blood, and generally a retroplacental clot is able to escape as the placenta is actually descending to the lower segment of the uterus. Remember that this retroplacental clot usually forms centrally and escapes following complete separation, but sometimes if the blood clot can find a path to escape, it may sometimes come out without the placenta not having completely detached, which is why this is not really a reliable indicator of complete separation of the placenta. So this sometimes can occur and has increased risk of bleeding and prolonged third stage of labor with the delivery of the leading edge of the placenta in the maternal surface. So we call this as the Matthews-Duncan method, rather than with delivery of the cord insertion and the fetal site, which is the more common, the Schultz method of delivery. So this is what's happening at the beginning of the third stage of labor. The placenta is still attached. Then here, the placenta is in the lower segment. As you can see, the uterus tends to rise towards the umbilicus. And of course, at the third stage, it tends to shrink and it will be contracted and to be below the umbilicus and will be firm and round. So here's an overview of how we carry out active management of the third stage of labor. There's administration of the uterotonic agent after delivery of the baby. There's expulsion of the placenta with controlled contraction. There's uterine fundal massage after expulsion of the placenta. So step 1 is administration of the uterotonic agent, which can be given after delivery of the infant. Please make sure that there is no second twin, because if you give a uterotonic and there's a second twin, then you are going to have the second twin being trapped on the inside, and you want to take this patient to theater. So the common agent that we use in our case in the drug of choice is oxytocin. We give it at 10 international units as IM, or sometimes we can give it as an infusion. So this is the most commonly used agent. It's the primary drug of choice. It can be used in patients that are hypertensive, and it's going to be given just after delivery of the front shoulder of the baby or after expulsion of the placenta. So generally it's administered as intramuscular. It can also be administered as an IV infusion. Even it's done usually during cesarean section as an IV infusion. And the oxytocin also decreases the postpartum blood loss when it's applied inside the placental cord. To some extent, we can sometimes give it in this route. The second drug is known as the methagene or methylgometrin, which is 0.2 milligrams IM. Remember that this one, egometrin, causes this continuous contraction of the uterus. So there's not enough evidence about its use as a single agent, but is typically administered at 0.2 milligrams IM. It should be avoided in hypertensive patients. Then we have a combination of methagene as well as oxytocin. 5 international units of oxytocin, 0.5 milligrams of methagene. So here, the time of onset of uterine response after the IM administration is much shorter than that of just the egometrin alone, and the duration of action is several hours, although it has been found to be much more effective than oxytocin. Then we have other drugs here like carbetocin, 100 micrograms, slow IV infusion. Remember, this one is given as a bolus over 1 minute instead of a continuous infusion and can be administered in elective C-section to prevent PPH in an attempt to decrease the need for therapeutic uterotonics. Carboprost can be given at 250 micrograms IM, and this is a synthetic prostaglandin. It's an analog of prostaglandin F2 alpha. And the main use of this is generally in obstetric emergencies of postpartum hemorrhage, which reduces the postpartum bleeding. The second step is, of course, controlled contraction. So this is the technique to assist in expulsion of the placenta. So remember that you're going to also delay the cord clamping, and this is going to be helping to reduce the chances of a retained placenta and subsequent bleeding due to PPH. You don't want to pull on the cord. You don't want to fiddle with the cord, because if you pull on it, sometimes it may snap and you begin to panic because the woman will continue to bleed. And more than equal to about 1 to 3 minutes after delivery of the baby, and you perform this controlled umbilical cord traction, we call this as the Brandt-Andrews maneuver. So one hand will be placed above the abdomen with your non-dominant hand, and will be pushing the uterus towards the mother's face, towards the mother's head. So it will be securing the fundus of the uterus, and the other one will be on applying steady traction in a downward manner. I've seen people twisting the umbilical cord, swaying it side to side. Don't do that. Just apply the cord traction with counter traction, and you should be able to deliver the placenta quite well. So this is how it's done. So as you can see, this arm is applying pressure above the pubic symphysis and supporting the fundus. This other one is applying pressure, pulling downwards. So this should be done with, of course, a contracted uterus that has been given oxytocin. Then remember that the clinician is going to be pulling the cord and placing the hand over the abdomen to detect any fundal contractions. And the placenta separation usually occurs during the first and second contraction, often with the gush of blood, with that retroplacental clot that slips and finds its way out through the vagina. Remember that the mother usually you can ask the mother to push down and bear down. This may sometimes help you deliver the placenta. If she cannot bear down, or if the bleeding is substantial, then the placenta has to be evacuated using your hand. I do talk about manual evacuation of placenta in the end of this particular lecture. So, and then you're going to be exerting this firm downwards or caudal pressure on the uterus with this procedure, and it should only be done if the uterus is firm, because if you do it with a flaccid uterus, it's going to invert. So if the procedure is not effective and the umbilical cord is still held tight, whilst the other hand is pushing on the abdomen, then you can continue with the traction. So if the placenta has not been delivered within 45 to about 60 minutes, then it has to be manually removed, and you need to give this patient some analgesia or anesthesia as required. Remember, for the manual evacuation, you're going to be placing your entire hand into the uterine cavity and actually separating the placenta, kind of like scraping it off from its attachment inside the uterus. I'll show you the technique of how it's done. So if it's actually adherent morbidly to the uterus and you actually can't determine the cleavage between the placenta and the uterus, then this may be suggestive of a placenta attachment disorder, which is known as a placenta accreta. So remember that the placenta, after is delivered, must be examined for its completeness, for any fragments that may be left in the uterus that may cause hemorrhage, that may cause infection later on. And if the placenta is incomplete, then you should explore the cavity manually. Although some obstetricians actually have routine exploration of the uterus after each delivery, but it's actually quite uncomfortable and not routinely recommended for all patients. Then with step 3, you're going to be performing a fundal massage immediately after you deliver the placenta. And this is going to be helping with the contraction of the uterus, and it's going to prevent PPH. Sometimes if bleeding is happening, you may perform a bimanual uterine massage. And this is the most common technique used, which is known as the Fisher maneuver and the Creed maneuver. So your clenched fist will be inserted into the anterior vaginal fornix, and then it's going to exert pressure on the anterior wall of the uterus, whilst the other hand will be on the position of the abdomen externally, and you'll be squeezing the uterus in between your hands. So remember that the fundal massage after the placental expulsion is going to be providing or helping with uterine contractions, and it's going to be stimulating endogenous prostaglandin secretion. Some adverse effects of the third stage of management of labor may be due to the uterotonic agents that may cause hypertension, they may cause nausea, they may cause vomiting. These are due to ergot alkaloids like ergometrin. It may also have a risk of placental retention, and there is a neonatal risk related to early cord clamping, things like iron deficiency anemia, intravascular hemorrhage, as well as hypotension. Now, in terms of a placenta that has been retained, remember that after birth, the placenta is going to deliver within half an hour, and sometimes the placenta may delay, or a piece of the placenta may be left behind within the uterus. So even if a piece has been left behind in the uterus, it will prevent the uterus from contracting and it will still keep bleeding. So you have to remove that small piece. You have to leave the uterus as clean as possible. So if the placenta is not delivered within 30 minutes, then the woman is not bleeding, then you can ask her to urinate, then give her a second dose of oxytocin. Continue with the cord traction and then encourage her to keep bearing down, but you don't have to give them misoprostol if you have already given them misoprostol. If the placenta has remained on the inside after 1 hour, or if the placenta has missing pieces, then and the woman is heavily bleeding, then you have to remove the placenta or the pieces with your hand manually. You shouldn't delay at any point. So the indications for manual removal of placenta include the placenta that is not expelled 30 to 45 minutes after delivery, hemorrhage prior to spontaneous expulsion of the placenta. And there are some precautions that have to be done, especially for all procedures that are intrauterine procedures. These are going to be minimizing the risk of bladder injury, and they're going to also help facilitate the procedure. So you're going to be doing these things before you actually do the manual removal of the placenta. Number one, you tell the woman to empty her bladder. So you can have her urinate on her own, or you can insert a sterile urinary catheter to drain the bladder. The second thing is that there must be a sepsis that is going to be there, so you should clean the vulva and the perineum with a povidone iodine scrub. Sometimes we use Savlon in our setting, and if it's not available, then we can use ordinary soap. We rinse and dry. And then we should perform vulvar swabbing with the perineal swabbing with about 10% povidone iodine solution. We can use Savlon in our setting here. We should use some sterile drapes and sterile compresses, sterile gloves. Ideally, those long gynecological gloves that cover up to the elbow are actually what you need in this case. Anesthesia should be done except in two situations where this woman is in a life-threatening emergency. For example, they're having a PPH because of the retained placenta. You have no time to administer the anesthesia, or if the anesthesia cannot be performed immediately. Wear your protective personal equipment because you're dealing with secretions, you're dealing with blood, which can carry these blood-borne illnesses. So make sure you wear your gloves, your gown, your rubber or plastic apron, a mask, and your protective eyewear. Cover this patient on some prophylactic antibiotics, sulfazoline or ampicillin. Slow IV injection, 2 grams is a simple dose. In our setup, we give ceftriaxone 2 grams and metronidazole 500 milligrams. Then, of course, a uterotonic agent must be given after the procedure to improve the contractions. In our case, we give oxytocin as an intravascular injection or as a slow IV infusion, 5 to 10 international units as a single dose. So how do you remove the placenta? So the step one is, of course, you tell the woman that you need to remove the placenta with your hand and you ask for consent. You make sure that she has an IV line and you make sure that the bladder is empty. You may give her some diazepam IV if she's not in shock. Don't give diazepam if she's in shock because you worsen things. Give her a single dose of antibiotics to prevent infections, in our case, ceftriaxone and metronidazole. Then you should wash your hands, put on your long sterile gloves that cover up to the elbow. You should wear your personal protective equipment. Then with your non-dominant hand, you're going to make a cup, and you're going to cup the fundus over the uterus. So with your left hand, you're going to place your left hand over the uterus and make a cup with your hand and cup the uterus, the fundus of the uterus on the abdomen. And this is meant to support the uterus and to keep it in place while it's removing. So here's a picture. So this is the non-dominant hand here, which is making a cup and cupping the fundus of the uterus over there. Then with your thumb and your palm together, you're going to insert your finger carefully, like flat, like as if you're trying to do a karate chop. But in this time, your karate chop is going into the vagina. So you'll be inserting your hand into the vagina in that fashion, in like a slit-like manner or in a flattened manner. And you're going to be moving it forward into the cervix and then eventually into the uterus. Now, if you have the umbilical cord there, you can actually have an assistant pull it a bit so that it's taut, and you can follow the umbilical cord until you reach its insertion. When you get now to the uterus on the inside, you're going to now want to determine the edge. You supinate your hand and you determine the edge. You find where the cleavage is, where there's a depression from where the uterus is to where now the placenta is. Then you begin to scrape off like a spoon. So once you find that cleavage plane, then you use one side of your supinated hand just like a spoon and you detach the placenta from the sides. Then you bring it out slowly with your hands. So like I said, this is the hand that's inside that's scraping like a spoon. Then you bring this out slowly with your hands. So you hold in place or hold the hand in the placenta that's inside there, and then as you're coming out, you make these twisting movements back and forth through the birth canal. Then you hold the placenta in both your hands and you twist it together at the membranes. When it comes out, remove everything that has or to prevent leaving anything behind. You reinsert your hand inside and you explore the uterine cavity to see if you haven't left any accessory lobes or haven't left any pieces inside the uterine cavity. Then you should check if the uterus is well contracted and massage it if it's soft. You examine the placenta and the membranes for that completeness and make sure that you put this woman on an oxytocin infusion. 20 international units and 1 liter of IV fluids, either Ringer's lactate or normal saline, to run at 60 drops per minute. You should teach the woman to monitor her uterus and should call you if the uterus becomes soft or if the bleeding has increased. So you should ideally monitor the pulse, the blood pressure, the uterine tone, the vaginal bleeding every 15 minutes for 2 hours. Then you can monitor it every 30 minutes for the next 6 hours or until this patient is stable. And remember that if the placenta cannot be easily separated from the uterine wall, you shouldn't force it. And if there's no cleavage plane that you can identify, you shouldn't force it, because this may be a placenta accreta. And this may be a patient that may need to be taken for surgery for a hysterectomy. So this would be a time where you would possibly inform the senior. I really hope you enjoyed this video on the active management of the 3rd stage of labor. If you did, consider subscribing to this channel, hit the bell notification icon to receive notifications of such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazeru. Until next time, bye-bye.